Dr. Gregory, I think your microphone is still muted.
Can you hear me? Can you hear this?
Yes, we can hear you now, sweetie.
Oh, wonderful, wonderful. Okay, all right, great. Sorry about that. Wrong microphone.
Gotta love technology.
Yeah. Okay, all right, so we'll get started. This is sort of an intro to pediatric neurology. And then we're also going to have a brief overview of headaches. So we'll get started with that. And if we have any time, maybe a brief overview of some seizure stuff as well, but I'm not sure if we'll have time for that or not, but the information will be included so you guys can look through it. So you guys may be aware we're hiring new staff. Hopefully she'll be starting in August sometime. But Cecilia Fernandez is onboarding right now. She's just finished training at Duke, I believe. And so she'll be joining our team. And hopefully Dr. Naharahi will be back sometime after Labor Day. So the team that you'll be seeing inpatient will be Dr. Fernandez, Dr. Lehman, Dr. Naharahi, Dr. Parrott, me. And then you'll also have an adult neurology resident working with us probably about half the time, maybe a little bit less this year because we're down a resident. And so sometimes they'll be sort of an intermediary, but we're not going to get upset if you contact us directly. I think almost all of us prefer being contacted by our cell rather than going through the pager because that just takes extra time. But certainly the pager is a way to get in touch with us during work hours. As far as the proposed schedule, a lot of that is going to depend on Dr. Fernandez getting onboarded on time and Dr. Naharahi coming back. So right now, as you're aware, Dr. Parrott is basically on in the hospital 3 weeks out of the month. And I'm taking the other week, but hopefully soon we'll be going back to a schedule similar to what we had before all of the chaos, where Dr. Parrott is on for a week each month, Dr. Naharahi is on for a week a month, and Dr. Fernandez is on a week a month. And then I take a week, but someone else will cover Monday and Tuesdays during that time. And then at some point during the month call, Dr. Lehman will be taking evening call. And again, we don't have a firm schedule set for call beyond August. And as of August, it's just me and Dr. Parrott. So, but hopefully things will stabilize a little bit. So you'll be getting the schedules and you may notice some new names on them. So how to place a consult, make sure it's ordered in the chart and then call us on the cell phone, or if you need to page us. If the adult neurology resident is rotating with us, then at least Monday through Friday, they'll be the first contact with the patient and probably with you as well, but we'll be involved. They're always closely involved with us and we don't mind being contacted, of course, directly. And sometimes you may be confused as to who's on service. I'll try to get the schedule to you as soon as they formalize it. They've had a little bit of chaos on their side as well, so we don't have the full neurology resident schedule. But you never go wrong with contacting the attending. So after we see a consult, we'll dictate it. It'll be in the chart within 4 hours. We'll also contact you directly and discuss our recommendations. For the discharge note, we'll have when we want to see the patient back in the office, any medication changes or other recommendations, and any additional orders, like if we're wanting to get an MRI as an outpatient or something along those lines, or referral to another service. That'll be mentioned in our final note. When you're trying to arrange a follow-up visit, messaging Lynn Medlin is probably your easiest way. You can do that through PowerChart. You can call her as well. She's on the phone a lot though. So as far as ordering EEGs, that's the major neurodiagnostic study that we're using. it's generally best to have us started from the beginning or involved from the beginning, just so we can help guide which study is appropriate. And also, there can sometimes be issues with availability of EEGs, so we're having to juggle them. So having us on board sooner is going to help you as far as getting what you need in a timely manner. You can order a routine EEG without a consult. That's fine. If you're going beyond a 1-hour EEG, though, I discuss it with us and put in a formal consult. There are special cases, of course, but this is going to help as far as the ease of what's going on. Plus, it helps us know what we're trying to look for as we read this EEG. You know, presumably someone on continuous video EEG, we're either trying to characterize episodes or determine a baseline cognitive function, or we're screening for like subclinical seizures. Whatever it is, it's something that we need to be involved in actively, generally. So in some cases, patients are going to be coming in specifically for epilepsy monitoring in our EMU. These are elective inpatient admissions. They're planned ahead of time, and so there should be a note detailing what the plan is, as well as a sheet, as you can see over to your right, that will have why we're performing the study. The important things there will be, you know, the indication. Are we trying to change therapy, or are we trying to characterize? Probably the most common thing we do is characterization, followed by trying to determine whether or not we can wean off of anticonvulsants. Semiology is also listed, and so that's going to give you an idea of clinically what we're looking for. We'll also have listed if we're planning on making any medication changes during the stay. Now, if we're bringing them in for characterization, we may not know what we're going to do until we see the EEG. But, you know, if we're planning on going down on something, or if we're planning to wean a medication upon admission, that's going to be in this paper as well as in the note. We'll also have special instructions included. That'll be primarily for the EEG techs, procedures and things that they can do to help bring on a spell or to avoid seizure if that's what we're trying for. So there's a lot of information in that sheet, but certainly, you know, call if there's any questions. Generally, we try to have pretty detailed clinic notes associated with admission, so you can look at our notes and see what we're trying to look for. And again, most of the time, the admission is going to be either a characterization of a spell, you know, is this a seizure or is it not? Or we have someone who is on therapy, they haven't had any seizures in 2 years, we're planning on trying to wean off medications, but we want to get a really good background before we try. So what we're looking for is any signs of the epilepsy is still lurking. There are some more complicated admissions from time to time, but I'd say 90% of our admissions are going to fall into one of those two categories. Generally, we say they arrive between 1 and 2 p.m. Sometimes that doesn't happen, but they can be hooked up by the techs through the night. But, you know, ideally it will be early enough so that we can all discuss and have a plan in place. Almost always, we're simply going to have Diastat ordered as a rescue medication. Occasionally, we may have a patient coming in where we're worried about convulsive seizures, particularly if we were in a situation where we were trying to wean medication during the stay. And in that case, we would want an IV placed for Ativan administration in case the person went into status. This is generally not something we're going to have to do with our stays, and we will be that will definitely be in our note if we need Ativan for this patient. So most of the time you can simply order Diastat with the age and weight recommendation dosing. And occasionally we may get you involved if the patient is moving around a whole lot. We're trying to keep them on camera. A lot of times we'll discuss this with the techs and try to get them to help us out. But occasionally you may be involved, particularly if there's something bizarre we need to do in order to trigger an event. We can work with like child life and everything, but have you guys on board as well. Most of the time, these run very smoothly, and we have our plan in place and everything goes accordingly. Every now and then, though, you can have some surprises. You have a patient come in for characterization and they are much sicker than we realized, or the EEG is markedly abnormal and the routine EEGs that were captured elsewhere were not characteristic. Sometimes when kids fall asleep, some really strange things can show up on EEG. So sometimes the plan does change, but just be in touch with us. You know, we're on call, we're available through the night. Let us know if something seems to be going wrong. Like you would do with the other continuous EEGs where, you know, the patient's coming in is a bit of a mystery. Calling for a consult regardless of reason, the things that our office has requested, look at the outpatient chart, see if this is a problem that has happened before. You know, probably the most common thing you're going to be seeing with our patients is breakthrough seizures. You know, check to see, is there a history of medical noncompliance, that sort of thing. You know, were we planning on changing medications? Were we weaning down on medications? Things like that. And the same goes for like someone coming in with a headache or any of our other regular kids where are we changing some sort of plan? Is there a probable explanation for what's going on, you know? Other things, examining the eyes. They can tell you a lot of information, but one of the major things, of course, is you want to see if these pupils are reactive and equal. We don't want people herniating on us. But also, it can give you a lot of other information as well, and as well regarding like mental status and such, and the cerebellar function. But the major thing is make sure those pupils are equal and reactive. Plotting head circumference can be useful, and the reason we bring this up is because we don't always get head circumference on admission. If we've got a dysmorphic kid, a developmentally delayed kid, particularly if this isn't someone we've been seeing in clinic, we need to get a head circumference at some point. That can be incredibly valuable. Either too big a head or too small a head can really lead us in different directions. So that's something that's important to get, and maybe not before you call for a consult, but certainly as we're getting the patient admitted, making sure you get that information. Trying to get videos of spells is really important as well whenever we're dealing with characterization issues. This particularly with seizures, but also with movement disorders, tics, dystonia, things like that, abnormal gait. It can be really valuable if you're able to get a video of the event. We can look at it. Sometimes we can come up with a diagnosis immediately, and most of the time it at least helps us rule out a few things and zero in on a few things. Google your concern, and always have a specific question. And that's not us just being mean. It helps to think about the case and to form a question before you call, to know what you're looking for and to help us know what you're looking for as well. And that also helps as you go through training, because every one of you is less than 3 years away from the real world. And you'll be the ones, you know, deciding what to do with patients. So it helps to have that practice of forming the question. As far as our goals for you on this rotation, what we want you to have by the time you graduate, the ability to do a good, thorough neurological exam. That's important for all general practitioners. And I can't think of really any specialist that it wouldn't be of some value to, maybe dermatology. But things to look for, you know, are the tendon reflexes present? Are they symmetric? You know, is the person dropping reflexes? Are they brisk on one side? Very important, and certainly changes to that are important. Being able to do a basic fundoscopic exam, particularly looking for papilledema, hemorrhages. We want you to be able to get a basic view. Now, that being said, with young kids, it simply may not be possible to get a good ophthalmoscope exam. With your teenagers, though, you should be able to. With the kids, sometimes it's simply not possible, and particularly without dilating the eyes. In those situations, we just have to get ophtho to help us. Determining other things on exam, ataxia versus weakness. Many times we're consulted for ataxia in a child that's just a little bit weak. And so being able to tell the difference really helps, because weakness can be a very serious thing, but it's caused by something different from ataxia. And certainly being familiar with stroke signs and how they can change through time. Kids have strokes pretty regularly. They're not like the adult strokes. They're generally for different reasons, but you're certainly going to come into contact with children who have had strokes in the past and maybe presenting with an acute stroke. And so very important to be familiar with that, and also with the long-term sequelae, after stroke, developing increasing tone in the affected extremities, things like that. And then being able to characterize abnormal movements. So, if you're looking at a child and you see them do something strange, is this a tic? Is this dystonia? Knowing what a chorea looks like, knowing these abnormal movements and being able to describe them, because it's going to be of value to you going forward as pediatricians. As far as diagnosing epilepsy versus non-epilepsy, you're probably going to get that very easily through the epilepsy monitoring unit. But other things, altered mental status, being able to assess that, and particularly being able to determine appropriate mental status for a child with developmental delays, that sort of thing. Being familiar with epileptic encephalopathies, where the patient has a multitude of symptoms, the actual seizures being the least important, although we need to definitely direct treatment towards it. But the systemic issues, structural issues within the brain, all of that being involved. And then probably the trickiest ones, I think, are the metabolic disorders. With this, what we want you to do is to kind of get some basic ideas as far as corralling them, when to be concerned, what might lead you in one direction versus another for metabolic disorder. And this kind of goes in conjunction with a lot of the genetic stuff that you'll be exposed to through Greenwood. So all of these are important. We also want you to be familiar with management of diseases. So basic seizure management, the medications you use. We don't expect you to start medications in the clinic environment on your own, but be familiar with the usual medications that are used for standard epilepsies, and be a little bit familiar with dosing. And as far as AED levels go, I think probably the biggest or the most common mistake that's made is whenever you're getting levels for oxcarbazepine, which is trileptal, many times carbamazepine gets ordered instead, and they're very related medications, but they're not identical. So if the patient's on oxcarbazepine and you order a carbamazepine level, the level's going to show up as low. And that doesn't mean they're not taking their medication. We just got the wrong level. So just let me know if you're having difficulties, any questions with that. I think that's the major one, that whenever we have levels that come back and are incorrect, that's the major thing. And I think it's because the medication sounds so much alike. So no management for first-time seizures, management for febrile seizures, and psychogenic or pseudo seizures. These are different, of course, as far as management compared to our chronic epilepsy patients. And then treatment for chronic migraine status, the various steps we go in, and we'll get to that a little bit later. Treatment for status epilepticus, being aware of non-convulsive status epilepticus as well as convulsive status. And then breakthrough seizures. The major reasons that we see them, probably non-compliance, at least in teenagers being the most common, but certainly illness and other things. So we're going to go now to our headache, and this is just a brief overview. You're going to get a lecture with some more details that really zero in on migraine and treatment and workup in a bit more detail. This is more of an overview of what do you need to know about a headache right away and how to rule out the really scary things and what to do in the acute setting for a severe headache. So we're not going to get into long-term treatments, any type of prophylactic medications. This is acute treatment only. So when you're evaluating a child with a headache, the major thing that you have to decide right away when you're seeing a child for the first time is this a scary headache or a more benign process? And essentially, headaches can fall into one of two categories. You either have a primary headache where the issue at hand is the headache itself, and there's no other health issue causing the headache. And then you have secondary headaches where other things are causing the headache. And sometimes those other things can be really scary, and sometimes they can be life-threatening. So generally in those cases, the treatment is going to be directed more towards the underlying issue. And sometimes these are more acute than others. Sometimes you have someone coming in with increased intracranial pressure that you have to deal with right away. Other times it may be a more gradual secondary type headache. So I would consider TMJ to be a secondary headache. Clearly, that's not something that's just acute and life-threatening, but certainly it needs to be dealt with. So with our primary headaches, the majority of the ones that you're going to see are going to be migraine or tension headache or falling somewhere along a spectrum. Kids tend to not have discrete headaches that are exactly like adults. They may not reach full criteria for adults for migraine, and they can still qualify as a child. And then we have a slew of children that have migraine type headaches. They don't meet full criteria, but they respond to the same treatments, and we basically do the same thing for them. You're going to find some more obscure headaches. Occasionally, kids will be admitted with cluster headaches. We have some hemicrania headaches, like the indomethacin sensitive headaches, and things of that nature that are going to have very specific treatments. But by far, the bulk you'll see are going to be either migraine or tension. As of the secondary headaches, what you're basically looking for with that is there any indication that something is going on and something else is going on that's causing the headache, and do we need to do something about it fast? So things to be looking for, is there any increased intracranial pressure, any signs that there might be? You can see this with tumor, brain edema for any reason, hydrocephalus. You can also see this with pseudotumor cerebri. We treat that one a little bit different, so I listed it separate, but you're going to be interested in the intracranial pressure with both. A head or neck bleed, you can have like a subarachnoid hemorrhage, an aneurysm. You can also have an injury to the neck that caused like a dissection of the artery, which can cause a substantial headache. Clearly, these are things that need to be treated surgically and need to be monitored very specifically. Meningitis, encephalitis, these can cause really bad headaches, and clearly treatment needs to be directed towards the infectious process. This isn't by any means a conclusive list. I'm just listing off some of the things that you need to look for. So your key to whether or not something's a primary headache versus a secondary headaches tend to be sudden, and they tend to be debilitating. So do they look as sick as they're reporting the pain? I find the 1 to 10 pain scales to not be really useful with kids. especially young kids, they're just not going to get it at all. But you can typically look at a child and tell how sick they are. Sometimes people can present, though, with like a first-time really severe migraine. So that isn't going to always help you totally rule it out. But anytime you're concerned that something strange may be going on, say someone presents with what sounds like a first-time migraine, but it's complicated, err on the side of safety and do additional workup. So the child presents to your office or to the ED with a complaint of headache. Is this an acute process or is this a recurrent headache? And if it's an acute process, are we dealing with a primary headache or a secondary headache? And what might the secondary headache be? So things to figure out quickly, and then things to figure out eventually. The type of headache, it isn't necessary in the ED to definitively determine tension versus migraine, but you need to figure it out at some point. What is going on that may be worsening the headache? This can be lifestyle-wise, it can be medications, all sorts of things. And what can the patient do to help the headache? And medical treatment for the headache. And some of these medical treatments, of course, are more outpatient type setting things, but it's good to think about, even if you're not going to be starting them in the inpatient setting. So warning signs. When you glance at the patient, does the child look sick? Do they look like they're really in pain? Is this a new type of headache? Is it something that came on suddenly? And is the headache rapidly worsening? Any of those should push you towards a more in-depth evaluation. Other warning signs, any signs of increased intracranial pressure, that would be a headache that's worse when you're lying down or with a Valsalva maneuver or straining, things like that. A headache that wakes you up from sleep. Vomiting associated with a headache, which you can see with migraine as well, but vomiting with a headache should have you at least thinking about the possibility of increased intracranial pressure. And papilledema, of course, on exam. Fever, nuchal rigidity, these should be things that have you thinking, hey, maybe this is an infection. Altered mental status. You can have confusional migraine, but that is certainly not a typical presentation with your standard primary headaches. And I would always err on the side of additional workup anytime a child has altered mental status, particularly if it's ongoing. And then focal neurologic deficits on exam, unless the child has CP at baseline and you know that there hasn't been a change, any sort of focal neurologic deficit that appears to be new, that's going to be concerning for, there being a mass, pressure, something going on inside the head that needs to be dealt with rapidly. So you're going to want to obtain a thorough HPI and PMH. Things that are important: headache quality, location, frequency, severity, all of these things that are going to help you kind of determine what type of headache, is there an aura? Are there things that can help it or make it worse? With really young children, this can be a little more difficult. Sometimes having them draw a picture of their headache can help. And then try asking open-ended questions, but you may end up getting to the yes/no arena. Children have been diagnosed with migraine as young as 18 months. I don't know how they did that, but apparently you can have a migraine that early. So yeah, the trick at that stage is going to be trying to get the information from the child to help you with that. And so, of course, it's important to note any medical conditions, comorbidities, any medications the child is taking, any changes to the medications, any allergies. Family history is really, really important. If you have a family history of hemiplegic migraine and the child comes in with hemiplegia and a headache, you're going to be far less concerned than if a child is showing up and there's no family history of that. I'd still be concerned about something else going on, and you're not going to be wrong to do additional workup, but you're going to be less scared if you have that family history. A social history can be of great use as well, particularly regarding stressors and triggers. And then physical exam, you want a complete neurologic exam with a headache. And sometimes this is going to take really annoying the patient to get a good exam because they feel bad and they don't feel like cooperating with you. And they're going to hate you for it, but a fundoscopic exam is necessary anytime you're evaluating a patient with headache, because you're wanting to look for any evidence of an increased intracranial pressure, and many times that optic disc bulging is going to be the first and best sign that you get. So, is there any evidence that something else is going on? Any evidence that we're dealing with a secondary headache? Acute onset new headache, rapidly worsening headache, awakening from sleep, nuchal rigidity, lateralizing signs, that's asymmetry, either with strength, reflexes, ability to follow commands, coordination, alterations of consciousness, evidence of ICP we discussed before, balance difficulties. And a lot of these are things that you can see at least briefly with migraine, but you can also see them with much scarier processes. And then also be aware of specific risk factors. You know, as a child on immunosuppressive agents and more likely to have an infection, maybe a more occult type infection, these kids need to be worked up more than other children. Or is this child at increased risk for having a stroke? If so, you know, you may want to do a neuroimaging a little bit more aggressively. If you answer yes to really any of these concerns, then you need to do additional workup. And that doesn't mean all of this for each patient, but as indicated. So most of the time, if a patient has a headache that you're worried about, you're going to get neuroimaging. You know, that's kind of the first step. If you have to get it really acutely, a head CT is okay. We prefer an MRI of the brain, but sometimes, you know, we can't get that. And if we're worried about someone having a hemorrhage, if we're worried about there being a tumor and the patient's exam is unstable, you know, if we're in a tight spot, get the head CT. That's not, you shouldn't be afraid of getting a head CT. If the child is more stable and we have the potential to get an MRI of the brain, that's the more preferable option, because you're going to get much better detail and be able to tell what's going on quite a bit better. But, you know, that's not going to happen over the weekend in a child that needs sedation. Getting an LP, many times we don't need to get this, but if we're worried about infection, you need to get it. If you're worried about pseudotumor, then we need to get that as well after we get the neuroimaging, and determining opening pressure. Labs, unless you're worried about a secondary process, labs are not useful. But if you're worried about a secondary process, then clearly, you know, if you're worried about infection, get infectious labs. If you're worried that the patient is having a headache because of a systemic disease, getting the appropriate labs for that. So your workup is going to be primarily neuroimaging with additional support as indicated. But if no, you know, this is a recurrent headache, it's the same as it's been before or just a little bit worse, you've got a normal exam and the patient doesn't have any risk factors that make you think they'd be at higher likelihood of having something else going on, what do you need to do? And so really the last time that they did a really thorough practice parameter, the American Academy of Neurology did this back in 2002, but their recommendations haven't changed. So the things that we always ask about, do we need to get labs? Do we need to get a lumbar puncture? An EEG, you'd be surprised how many times people get EEGs for headaches. Neuroimaging, you know, do we need to get these things? And I'm gonna fly through this, but basically none of them are indicated. unless you have suspicion for something else. If this is a routine situation, there's no need to get any of this workup. Now, if you have any of those warning signs we talked about earlier, you may need to get these. So what you need to be doing is focusing on appropriate diagnosis and treatment in a recurrent headache. And the recurrent headaches, these primary headaches, these are going to be the vast majority of the patients that come in that we see, but not all of them. So recommendations for treatment are to treat them consistently and rapidly to get the patient back to their normal functioning level. You want to optimize the patient self-care and get them more feeling more empowered to take care of themselves and doing what is going to be best for them, minimizing the use of rescue medications and cost effective, of course. And then you want the treatment to not have a lot of side effects. So if someone needs to be on long-term medication, having something that isn't impacting their life as badly as a headache would have. In the acute setting, of course, where we're looking at headache pain decrease, generally it's not cessation, but a decrease to a level where the patient can go home. We have various treatment options, long-term and short-term, but what we'll be focusing on today is going to be our short-term treatments. And so as far as treatment in an inpatient or an outpatient setting, there's data to support the use of Tylenol, ibuprofen, and intranasal triptan use. The oral triptans were not as effective. The data has been much more variable and inconclusive. The nasal sumatriptan has had several studies that have shown it to be efficacious, which is not to say you shouldn't use oral triptans, but if you're using oral triptans and they're not working, it may be worth trying intranasal sumatriptan just to see if that might have an effect, because patients do show better response to it, but they have to tolerate the nasal spray, and a lot of people don't. As far as just acute management of pain, IV compazine works really well. It's shown efficacy to be superior to ketorolac. It's also been shown superior to opiate uses, which you should never ever use for headaches, except for very rare settings. But compazine is lovely, lovely. You can also use Reglan if compazine is not indicated for a particular patient, but there's more data supporting compazine's use in a migraine cocktail than anything else. Other things, DHE in kids, there haven't been really great studies showing effectiveness, but just based on adult research, it probably is effective. So certainly in some of these kids that are super refractory, we can try a trial of DHE using the Raskin protocol. So IV combination therapy, the one that has been shown to be they haven't had like side-to-side competition, but your gold standard type research, but the one that has the greatest support in studies is going to be a normal saline fluid bolus, either ketorolac or an oral like ibuprofen, compazine, and then Benadryl. You're going to want to always use that with compazine to avoid a dystonic reaction. If a patient has a dystonic reaction, they're never going to take compazine again willingly. So just make sure to give it with the Benadryl. The Benadryl helps as well. And so this can be used in the emergency department. If the patient starts feeling better, they can sometimes go home with having had the IV cocktail and then an oral cocktail. Many times, though, the pain is not going to decrease enough, and so you're going to end up having to admit them and continuing your migraine cocktail. And so this is just more details. So your IV cocktail hasn't worked. Continue the cocktail, but try adding in magnesium. You'll want to get a magnesium level first. But unless it's high, you can give them a dose of magnesium. Like adult size would be like 1 gram. Valproate, Depakote, you can give a dose of that. You're going to want to have a negative pregnancy test beforehand, and ideally liver functions. And I wouldn't use that in super, super, super young children unless everything else has failed. And then steroids. The one thing that I will mention with steroids is oftentimes it helps, but it's not going to help just right away. So this is something that you're going to see kick in maybe 2 or 3 days down the road. So it's not bad to use steroids, but unlike magnesium and Depakote, where you might see an effect right away, with steroids, you're not going to see that. You're planning more for long-term control. With Depakote, the best effect is if you can push it, but I don't think our floors allow that. It has some efficacious efficacy in just a standard drip. So it doesn't have to be pushed, but it seems to work best that way. And then the Raskin protocol for DHE, if all else fails, do not use opiates for migraine or for your recurrent primary headaches. There are settings when opiates are appropriate, but I think those are mostly limited to the HEMOC setting. The risk with using opiates in children to treat chronic headache is 2 separate things. So first, you're risking addiction, but secondly, there's increased risk of transforming into status migrainosis, where you have a migraine that just doesn't go away. People have a much higher rate of having this transformed migraine when they're treated with opiates or with barbiturates. So don't do that. So just for review, the warning signs that you're going to be looking for headache. Does the child look sick? Is this a new type of headache? Is it a sudden onset? Is the headache rapidly worsening, or is it very severe from the start? All of those are going to be major warning signs. Other things to ask about that may not be apparent when you first walk into the room. What makes the headache worse? Is it upon lying down? Does the headache wake the child up from sleep? Is there vomiting associated with the headache? Is there papilledema on exam? Any fever, any nuchal rigidity, any altered mental status, any focal neurologic deficits, any of these things, and we're going to be going for neuroimaging, and depending on what we're looking for, also going for potentially an LP, labs, that sort of thing, and treating appropriately. So these are the references for the headache. Do you guys have any questions? You'll be getting more about headaches, specifically like criteria for migraine in children, that sort of thing, and treatment in the outpatient setting later. The major thing that we wanted to give you right away was, what to look for a headache that would make you concerned and you'd want to do additional workup versus something that can be, deferred to outpatient treatment. So it looks like I've used up all of my time. I anticipated that, but I do have a few slides later on, and I'll make sure you guys have access to it. But basically, just stating things to look for with seizures when you're trying to decide what workup to do in the emergency setting. So I'll click through it if you have a chance, but that was not on the agenda for today. So I'm not seeing any comments coming up. So I'm hoping that means you don't have questions rather than I'm just not seeing them. But if you have questions and you're trying to get in touch with me, text me. My phone number's in the PowerPoint. We'll make sure it's saved so you guys can get back to it, and send me an email, whatever. I'm happy to answer questions. So thank you guys for your time, and sorry for the audio difficulties earlier on.